If you've been taking blood pressure medication for years, there's one question I want you to ask yourself. When was the last time anyone explained what those pills might be doing to your kidneys? Not what they do for your blood pressure. What they may slowly be doing to the organs that clean every drop of blood in your body. Because kidney damage doesn't begin with pain. It begins with silence. There are no alarm bells, no sharp sensations, no urgent warnings in the middle of the night. Just a quiet shift in your chemistry that most people never notice until it shows up on a lab result. And by then, the conversation has already changed. I want to be very clear. The medications we're going to talk about today save lives. They prevent strokes. They protect hearts. They add years and quality to your life. But like all powerful tools, they require understanding. And that understanding is what I want to give you today. Because millions of seniors across the United States take these medications every single day. And most have never been told what happens when those medications meet dehydration, or a stomach virus, or a bottle of ibuprofen, or even just the natural aging of the kidneys themselves. This isn't about fear. This is about knowledge. The kind of knowledge that can prevent a hospital admission. The kind that helps you recognize warning signs early. The kind that turns you into an active partner in your own care. I'm Dr. Emily Carter. I've spent more than 3 decades caring for older adults with heart disease, kidney disease, and high blood pressure. I've sat beside hospital beds at 2 a.m. I've held the hands of patients who didn't understand why their kidneys suddenly stopped working. And I've had hundreds of conversations that should have happened years earlier. This channel exists because the conversations that truly protect your health rarely fit into a 15-minute office visit. So today, I'm going to take all the time we need. Let me tell you about Margaret. Margaret was 72 years old. She had worked for decades as a librarian in a small town in Pennsylvania. Quiet, organized, someone who followed instructions to the letter. She had been taking lisinopril for her blood pressure for nearly 8 years. 10 milligrams every morning. Her pressure was beautifully controlled. Her doctor was pleased. Margaret felt fine. Then one weekend in late summer, she came down with what she thought was a simple stomach bug. Vomiting, diarrhea. Nothing she thought was serious enough to call anyone about. She figured she'd write it out at home like she always had. By Monday, she felt weak, dizzy, a little confused. Her daughter stopped by that afternoon and found her sitting on the edge of the bed, disoriented and pale. They went to the emergency room. Margaret's creatinine, a marker of kidney function, had more than doubled. Her potassium was dangerously high. She was admitted immediately. What happened? Margaret had become severely dehydrated, and when your body doesn't have enough fluid, your kidneys don't get enough blood flow. Add a medication like lisinopril, which changes the way blood moves through the kidney's filtering system, and you have a perfect storm. Margaret recovered, but it took weeks. And it could have been prevented with one simple piece of information. When you're sick, some medications need to be paused. That's called a sick day plan. And Margaret had never heard of it. Margaret's story is not unusual. In fact, it's one of the most common reasons older adults end up in the hospital with acute kidney injury. So today I'm going to walk you through 7 blood pressure medications, or classes of medications, that can affect your kidneys when used incorrectly or under certain conditions. I'll explain how each one works, why doctors prescribe it, how it can stress the kidneys, who's most vulnerable, what the early warning signs are, and most importantly, how to reduce your risk. This is not a reason to stop your medication. It's a reason to understand it. Let's begin. The first group is called ACE inhibitors. These include medications like lisinopril, ramipril, and enalapril. They're some of the most commonly prescribed blood pressure medications in the United States, and for good reason. ACE inhibitors work by blocking an enzyme in your body that tightens blood vessels. When you block that enzyme, your blood vessels relax. Your blood pressure comes down. Your heart doesn't have to work as hard. And for people with diabetes or early kidney disease, ACE inhibitors can actually protect the kidneys over time. That's why doctors love them. And in the right patient, they're incredibly effective. But here's what most people don't know. ACE inhibitors change the pressure inside the tiny filters of your kidneys. Normally, your body tightly controls that pressure to keep your filtration rate stable. ACE inhibitors relax the blood vessel that carries blood out of the kidney filter. That lowers the pressure, and in most cases, that's fine. But if something else happens that drops your blood flow, like dehydration, vomiting, diarrhea, or even starting a diuretic at the same time, your kidneys may not be able to compensate. The filtration rate drops, waste products start to build up, creatinine rises, potassium rises, and this can happen fast. Let me tell you about James. James was 76, a retired electrician from Ohio. He'd been on Ramapril for about 5 years. His blood pressure was perfect. He felt great. Played golf twice a week. One summer, his doctor added hydrochlorothiazide, a diuretic, to help bring his pressure down just a little more. It was a small dose, a common combination. But James didn't increase his water intake. He kept playing golf in the heat. He kept drinking his usual 2 cups of coffee in the morning and maybe a glass of water at lunch. Within 3 weeks, he started feeling off. Tired. A little nauseous. He thought maybe he was overdoing it. His daughter, a nurse, convinced him to get his labs checked early. His creatinine had gone from 1.1 to 2.3. His potassium was 5.7. His doctor immediately stopped the diuretic and had him drink more fluids. Within 10 days, his creatinine came back down. But it was a close call. James didn't know that adding a diuretic to an ACE inhibitor meant he needed to be much more careful about hydration. No one had told him. So who is most vulnerable when taking ACE inhibitors? Older adults over 70, people with existing kidney disease, anyone who becomes dehydrated, people taking NSAIDs like ibuprofen or naproxen, those on diuretics, and people with heart failure. Early warning signs include fatigue, nausea, decreased urination, swelling in the legs or ankles, confusion, and muscle weakness. If you're on an ACE inhibitor, here's how to reduce your risk. Stay hydrated, drink water throughout the day, not just when you're thirsty. Avoid NSAIDs unless your doctor says it's okay. Get your kidney function and potassium checked regularly, especially in the first few weeks after starting the medication or changing the dose. And if you get sick with vomiting or diarrhea, call your doctor. You may need to pause the medication temporarily. This is not something to be afraid of. This is something to be aware of. The second group is very similar. They're called ARBs, or angiotensin receptor blockers. These include losartan, valsartan, and olmesartan. ARBs work almost the same way as ACE inhibitors, just at a different point in the system. They block the receptor that tightens your blood vessels instead of blocking the enzyme. The end result is the same: lower blood pressure, less strain on the heart, protection for the kidneys in many patients. And just like ACE inhibitors, ARBs can cause the same kind of kidney stress under the wrong conditions. Dehydration, illness, NSAIDs, diuretics, all the same risk factors apply. The good news is that the monitoring is the same. Regular lab work, attention to hydration, awareness during illness. One thing that's important to know is that you should never take an ACE inhibitor and an ARB together unless a specialist has specifically told you to. Years ago, doctors thought combining them might give extra protection. but research showed it actually increases the risk of kidney damage and high potassium without added benefit. So if you're on one, you should not be on the other. Have you ever been given a sick day plan by your doctor? I'd love to hear your experience. Drop a comment below and let me know. Now let's talk about diuretics, water pills. These include hydrochlorothiazide, chlorthalidone, and furosemide, also called Lasix. Diuretics help your kidneys remove extra salt and water from your body. That reduces the volume of fluid in your blood vessels, which lowers your blood pressure. They're especially helpful for people who retain fluid or have heart failure, but here's the trade-off. Diuretics make you urinate more. And if you're urinating more, you're losing fluid. If you don't replace that fluid, you become dehydrated. And dehydration reduces blood flow to the kidneys. For most people, this isn't a problem. But if you're older, if you're on other medications, if you're sick, or if it's hot outside and you're sweating, that dehydration can tip you into trouble. Let me tell you about Linda. Linda was 69, a retired teacher from Arizona. She'd been on furosemide for heart failure for about 2 years. It helped her breathe easier, kept the swelling down in her legs. She was careful. She weighed herself every day like her cardiologist told her to. She took her pill every morning. But one week in July, temperatures hit 110 degrees. Linda didn't have air conditioning. She stayed inside, drank iced tea, tried to stay cool. By the end of the week, she felt terrible, weak, lightheaded, confused. Her son took her to the emergency room. She was profoundly dehydrated. Her sodium was dangerously low. Her creatinine had tripled. She spent 4 days in the hospital on IV fluids. Linda didn't realize that in extreme heat, she needed to drink much more water, even while on a diuretic. She thought the iced tea was enough. It wasn't. Diuretics are life-saving, but they require balance. If you're on a diuretic, you need to drink enough water. You need to monitor your weight. A sudden drop in weight can mean you're losing too much fluid. A sudden gain can mean you're retaining it. You also need to watch your potassium. Some diuretics, like hydrochlorothiazide and furosemide, cause you to lose potassium. Others, like spironolactone, cause you to keep it. Your doctor should be checking your potassium regularly. And if you get sick, especially with vomiting or diarrhea, you need to call your doctor. Continuing a diuretic while you're already dehydrated can be dangerous. Let's talk specifically about potassium-sparing diuretics like spironolactone. These are often added to other blood pressure medications or used in heart failure. They help your body hold on to potassium while still removing fluid. That sounds good, and for many people it is. But if your kidneys aren't working perfectly, or if you're also on an ACE inhibitor or an ARB, your potassium can climb too high. High potassium, called hyperkalemia, is dangerous. It affects your heart rhythm. It can cause sudden cardiac arrest. The tricky part is that high potassium often has no symptoms until it's severe. Some people feel weak, nauseous. Their heart may feel like it's skipping beats. That's why regular blood tests are so important. If you're on spironolactone, your doctor should be checking your potassium and kidney function every few months, sometimes more often. And you should avoid potassium supplements, salt substitutes that contain potassium, and even large amounts of high potassium foods like bananas, oranges, and tomatoes, unless your doctor says it's safe. Robert was 81, a retired carpenter from Michigan. He had heart failure and took spironolactone along with lisinopril. His potassium had always been fine. Then one winter, he caught a cold. He didn't feel like eating much. He got a little dehydrated. He went in for a routine lab check, and his potassium was 6.4. That's critically high. He didn't feel anything unusual, no chest pain, no palpitations, just tired. His doctor stopped the spironolactone immediately and rechecked his labs 2 days later. His potassium came down. Crisis averted, but Robert had no idea how close he'd come to a life-threatening heart rhythm. Now I want to talk about something that isn't a blood pressure medication, but it's so important I can't skip it. NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, Advil, Aleve. These are over-the-counter pain relievers that millions of people take every day. And they can seriously harm your kidneys, especially if you're older, dehydrated, or already on blood pressure medication. Here's why. Your kidneys need a steady flow of blood to function. NSAIDs reduce that blood flow by blocking chemicals that keep the blood vessels in your kidneys open. If you're young and healthy, your body can usually handle that. But if you're over 60, on a diuretic, on an ACE inhibitor, or on an ARB, and you add an NSAID, you've just created what we call a triple whammy. The diuretic reduces your blood volume. The ACE inhibitor or ARB changes the pressure in your kidney filters. And the NSAID reduces the blood flow. All three together can cause acute kidney injury. I've seen this happen more times than I can count. A patient with perfect kidney function takes ibuprofen for a few days for back pain, and suddenly their creatinine doubles. Evelyn was 74, a retired seamstress from North Carolina. She'd been on losartan and hydrochlorothiazide for years. Her kidneys were fine. Then she developed a pain in her shoulder. She didn't want to bother her doctor, so she bought ibuprofen at the pharmacy. Took it 3 times a day for a week. By the end of that week, she felt awful. Swollen, nauseous, barely urinating. She called her daughter, who brought her to the hospital. Her creatinine was 4.2. She was in acute kidney failure. They stopped the ibuprofen, stopped the blood pressure medications temporarily, gave her IV fluids. Slowly, her kidneys recovered. But Evelyn's kidney function never fully returned to where it had been. She now has stage 3 chronic kidney disease, all from a week of over-the-counter ibuprofen. If you're over 60 and on any blood pressure medication, please talk to your doctor before using NSAIDs. There are safer alternatives for pain. Acetaminophen, also called Tylenol, doesn't affect the kidneys the way NSAIDs do. It's not perfect for every type of pain, but it's much safer for your kidneys. If you absolutely must use an NSAID, use the lowest dose for the shortest time, stay very well hydrated, and let your doctor know this is one of the most preventable causes of kidney injury I see, and it breaks my heart every time. Let's talk about sick day rules. This is one of the most important things I teach my patients, and yet most people have never heard of it. When you're sick, especially with vomiting, diarrhea, fever, or anything that makes you dehydrated, certain medications can become dangerous. LCE inhibitors, ARBs, diuretics, sometimes even metformin if you're diabetic. During illness, your body is already stressed. You're losing fluids, your blood pressure may drop, your kidneys are getting less blood flow. If you keep taking medications that lower your blood pressure further or remove more fluid, you can tip into kidney failure. That's why many doctors now give patients a sick day plan. It's a simple list that says, if you're vomiting, if you have diarrhea, if you can't keep fluids down, stop these medications and call me. It's not forever. It's just until you're feeling better and eating and drinking normally again. But you have to know to do it. And most people don't. If you've never been given a sick day plan, ask your doctor at your next visit. Write it down, keep it somewhere easy to find, share it with your family. It could save your life. I want to spend a moment on dehydration because it's the common thread running through almost everything we've talked about today. As we age, our sense of thirst decreases. You may not feel thirsty even when your body desperately needs water. Your kidneys also become less efficient. They can't concentrate urine the way they used to, so you lose more water. Add a diuretic, and you're losing even more. Add heat or exercise or illness, and suddenly you're in trouble. Dehydration doesn't just make you feel bad. It reduces blood flow to your kidneys. It makes your blood pressure medications more powerful. It raises your creatinine. It increases your risk of falls, confusion, and hospitalization. So, how much water should you drink? There's no one-size-fits-all answer, but a general rule is to aim for 6 to 8 glasses of water a day. More if it's hot or you're active. Your urine should be pale yellow. If it's dark, you're not drinking enough. And if you're on a diuretic, talk to your doctor. Some people need to limit fluids. Others need to drink more. It depends on your heart, your kidneys, and your specific situation. Now let's talk about the warning signs your kidneys may be in trouble. Remember, kidney damage usually doesn't hurt. You won't feel it, but your body will give you clues. Fatigue that doesn't go away. Feeling more tired than usual even after rest. Swelling in your ankles, legs, or feet, especially at the end of the day. Puffiness around your eyes in the morning. Changes in urination, urinating much more or much less than usual. Foamy urine, dark urine, nausea or loss of appetite. Trouble concentrating or confusion. Muscle cramps or weakness. Dizziness, especially when standing up. Any of these symptoms, especially if they come on suddenly or after starting a new medication, should prompt a call to your doctor. Don't wait. Don't assume it's just part of getting older. Your kidneys are talking to you. Listen, let me tell you about Charles. Charles was 78, a retired postal worker from Georgia. He'd been on enalapril and chlorthalidone for years. Everything was stable. Then he started noticing that he was urinating less. His ankles were swelling. He felt tired all the time. He didn't think much of it. He figured maybe he was retaining a little water. Maybe he needed to cut back on salt. His wife noticed the swelling and insisted he call his doctor. They ran labs. His creatinine had gone from 1.3 to 3.1 over the course of 6 months. His eGFR, a measure of kidney function, had dropped to 28. He was in stage 4 chronic kidney disease. Charles had been slowly losing kidney function and he hadn't noticed. His body had been compensating. But by the time the symptoms showed up, significant damage had already occurred. His medications were adjusted. He started seeing a nephrologist. He made dietary changes. But he wished he'd known to get his labs checked sooner. This brings me to lab work. If you're on blood pressure medication, especially ACE inhibitors, ARBs, or diuretics, you should be getting your kidney function and electrolytes checked regularly. That means a basic metabolic panel, which includes creatinine, eGFR, sodium, and potassium. When you first start a medication, your doctor will usually check labs after a week or two, then again in a month or two. After that, it depends. Some people need labs every 3 months, others every 6 months. It depends on your age, your kidney function, and what other conditions you have. But here's the thing. You have to actually go get the labs done. I can't tell you how many times I've ordered labs and the patient doesn't follow through. Life gets busy, you feel fine, you forget. But that lab work is your early warning system. It tells us what's happening inside your body before you feel anything wrong. So please, if your doctor orders labs, make it a priority. Put it on your calendar. Treat it like the important appointment it is. Let me explain 2 numbers you should know. Creatinine is a waste product made by your muscles. Your kidneys filter it out of your blood. If your kidneys aren't working well, creatinine builds up. A normal creatinine is usually between 0.6 and 1.2, but it can vary. EGFR stands for estimated glomerular filtration rate. It's a calculation based on your creatinine, age, sex, and race. It estimates how well your kidneys are filtering. A normal EGFR is over 90. Anything below 60 suggests some degree of kidney disease. Below 30 is severe. Below 15 is kidney failure. If your EGFR is dropping, that's a red flag. It means your kidneys are losing function. Sometimes it's temporary. Sometimes it's permanent. But either way, it needs attention. Ask your doctor what your EGFR is. Write it down. Track it over time. Knowledge is power. I want to briefly mention calcium channel blockers like amlodipine and diltiazem. These medications are generally very safe for the kidneys. They work by relaxing the blood vessels, but they don't change kidney pressure the way ACE inhibitors and ARBs do. That's why they're often used in people with kidney disease. But they can cause swelling in the ankles and legs, which people sometimes confuse with a kidney problem. That swelling is usually just from the way the medication affects the blood vessels in your legs, not from your kidneys or your heart. If you notice swelling, mention it to your doctor, but don't panic. It's usually manageable. Beta blockers like metoprolol and atenolol are also generally safe for the kidneys. They work by slowing your heart rate and reducing the force of your heartbeat. They're not typically a direct cause of kidney problems, but in people with very low blood pressure or severe dehydration, they can contribute to reduced kidney blood flow. The principles are the same. Stay hydrated, monitor your labs, pay attention to symptoms. So let's bring this all together. Blood pressure medications are some of the most important tools we have in medicine. They prevent heart attacks, they prevent strokes, they save lives every single day. But they are powerful, and power requires respect. Your kidneys are not separate from your heart. They work together. What helps one can sometimes stress the other, especially under the wrong conditions. The goal is not to avoid these medications. The goal is to use them wisely. That means staying hydrated, avoiding NSAIDs when possible, getting regular lab work, knowing your numbers, having a sick day plan, and asking questions. It means being an active participant in your care, not a passive recipient. And it means understanding that your body at 70 is different than it was at 50. It needs more attention, more care, more gentleness. That's not weakness. That's wisdom. I want to end with one more story. Her name was Dorothy. She was 83, a retired nurse, sharp as a tack. She came to see me because she wanted to understand every medication she was taking. She brought a list. She asked about each one. She asked what could go wrong. She asked what to watch for. I spent 45 minutes with her. We went through everything. 6 months later, she got a stomach flu. She remembered our conversation. She stopped her lisinopril and her hydrochlorothiazide. She drank as much as she could. She called my office the next day to let me know. Her lab stayed stable. She restarted her medications a few days later. No hospital, no complications. Dorothy protected herself because she had the knowledge to do so. That's what I want for you. These medications save lives. They've extended the lifespan and improved the quality of life for millions of people. I prescribe them every single day, and I will continue to do so. But knowledge makes them safer. Your kidneys deserve just as much attention as your heart. They work silently, filtering your blood, balancing your electrolytes, regulating your blood pressure. And when they fail, everything else starts to unravel. So please take this information seriously. Talk to your doctor, get your labs done, stay hydrated, know your medications, know your body. If this video helped you, I'd be so grateful if you'd hit the like button and subscribe to this channel. Share it with a family member or friend over 60. This is the kind of information that doesn't always make it into the exam room, but it can change the outcome. After this video, I want you to watch my guide on the early warning signs your kidneys may be sending before permanent damage begins. It's linked right here on the screen. I'm Dr. Emily Carter. Thank you for spending these moments with me. Take good care of yourself, and I'll see you in the next video.